Pulmonary embolus is the third commonest cause of death for venous thromboembolism in Europe. So in one typical year, there'll be about 380,000 deaths from VTE in Europe. It's a massive problem. It occurs in patients who are sick, patients who are well, the elderly, the young. It's cross-sectional across adult society, and it is a major burden on healthcare resources. About 60% of patients will present with a low-risk PE, quite a simple, small pulmonary embolus. Maybe they get breathlessness, chest pain. They'll present to their A&E, abnormal blood test. A CT scan will show some clot in the lung, and they will be discharged potentially the same day with anticoagulation, and will have no long-term sequelae, most of those patients. The group that we're talking about at the European Society of Cardiology, and more research is ongoing, and is the higher risk groups. So the intermediate risk groups, the high risk groups, who will present with strain in the right side of the heart, low oxygen levels, perhaps compromised blood pressure, and those patients should be considered for alternate strategies. And that's what we've been talking about this week. So there are various technologies that are available for interventions in PE. There's only one that's approved by the American Food and Drug Administration, and that's an ultrasound catheter called the Acoustic catheter. It's a percutaneously delivered technology through the venous system, and what it involves is wiring up to the lung under local anesthesia, siting these two sheaths, which have two functions. The first is to allow the siting of an ultrasound catheter, which delivers low power, high frequency energy directly into the clot. These devices are strapped in and left there for a period of hours. And then the second function is to allow it to deliver thrombolytic agent. So traditionally there have been two ways of treating pulmonary embolus: simple anticoagulation and systemic thrombolysis. So the current FDA recommended treatment protocol is for alteplase, which may be a bolus of 20 milligrams followed by a further 80 milligrams depending on the patient's body weight. So a 100 milligram dose of alteplase for high-risk pulmonary embolus, so-called massive pulmonary embolus, that's designed to be given to a small subset, 5% of people with pulmonary embolus who have got low blood pressure, strain on the right side of the heart, and who are compromised and have a very high risk of early mortality. So about 50 to 60% of these patients will die in the first hour, and a high proportion of the rest will die as inpatients unless they receive aggressive thrombolytic treatment. This group in the middle, the intermediate risk patients, their mortality is more of the order of 5 to 10%, and they can be risk stratified and selected for this percutaneous technology, which may be an option in them, where we deliver ultrasound-assisted thrombolytic at a much lower dose. So the first trials were using 20 to 24 milligrams delivered through these catheters, when using ultrasound to potentiate the action of thrombolytic through acoustic streaming. So effectively the device injects this small dose of thrombolytic directly into the clot within the lung over a period of hours. And also it thins the fibrin mesh and encourages penetration of these small doses of TPA directly locally into the clot. So the first two studies, Optimum, which is a randomized study, had used 20 milligrams and had shown that a much faster resolution of RV strain. The second study, Seattle 2, which was a single-arm study, had shown again that this technology can safely offload the right ventricle in a short period of time within a matter of hours. Now we're reporting at the European Society of Cardiology the results of the Optimum study. Optimum has looked at even lower doses of thrombolytic. So instead of the 100 milligrams of systemic alteplase that was traditionally given for pulmonary embolus, or even the 20 or 24 milligram doses used in the first studies of catheter-directed thrombolysis with ultrasound, Optimum is randomized to 100 patients in America and in the United Kingdom to 4 different treatment protocols. So the first was 8 milligrams over 2 hours, 8 milligrams over 4 hours, 12 milligrams over 6 hours, 24 milligrams over 6 hours. So shorter protocols and smaller doses. And what it showed is that at 48 hours, CT scans showed that the right ventricle had come down by a substantial amount. So we talk about the RV-LV ratio on CT when we're measuring the degree of RV strain. Typically, if someone has an intermediate high-risk pulmonary embolus, you'd have a ratio of the order of 1.3, 1.4. What the CT showed which were published at the American Thoracic Society back in March by Dr. Tapson, was a reduction in the RV-LV ratio of 0.4, which is a substantial offloading of the right ventricle. And here at the European Society of Cardiology, Dr. Piazza from Harvard has reported the echocardiographic findings at a similar time point, and again showing offloading with all 4 treatment strategies. So this was quite a surprise to us, that 8 milligrams of alteplase could offload the right ventricle, as demonstrated by CT and at this meeting by echo, at an early time point of 48 hours, suggesting that we can treat these patients with very low doses in a very safe fashion and minimize bleeding risk and costs by shortening the treatment. So Optimum was 100 patients, and it's shown that perhaps the 24 milligrams over 6 hours dose is not necessary, that there was one serious bleeding event and then a secondary bleeding event in that group. So we have set aside that arm and now are looking at the 3 lower dose arms in a future study that's going to take place in the United Kingdom. So this is going to extend Optimum within the UK. It'll be a multi-center study. We actually opened last week, and Exeter was the first site, and it's going to be taking place at multiple sites around the country. The aim is to extend our understanding of the impact of these short protocol, low-dose thrombolytic treatments on intermediate risk pulmonary embolus to try and establish whether we can change the paradigm for treatment for this condition to one of rapid early intervention with a low bleeding risk, and try and offload the right ventricle earlier to avoid this 5 to 10% risk of cardiovascular collapse or death that can occur in intermediate risk pulmonary embolus in the first 7 days of treatment. So I came to this field relatively recently. Cardiologists in the UK have not always taken an important role in the management of pulmonary embolus, and that's partly because of the treatments that were on offer. We've had simple anticoagulation, where a lot of these patients are turned around in A&E and in medical units, and then we have high-risk patients, which would get systemic thrombolysis and perhaps come to coronary care. But this field, I think, has been led by specialists in vascular medicine, respiratory medicine, acute medicine. I think cardiologists can play a role now, particularly with these percutaneous technologies, working closely with our colleagues in interventional radiology, who also have been providing catheter-directed treatments over the years, perhaps not at large volume, but have certainly been doing it. And I think this is a real opportunity for interventional cardiologists and interventional radiologists to look at new ways of treating pulmonary embolus in this quite large group of patients. We're talking about somewhere between 10 and 20,000 patients in the UK per year will present with an intermediate risk pulmonary embolus, and perhaps half of those could be candidates for catheter-directed treatment. I think we need to build the evidence base, but I think there's an increasing role now for interventional specialists to get involved in pulmonary embolus, and I would encourage them to do so.